Hey, everybody. I'm here with Dr. Ian Harris. He is a professor of orthopedic surgery at the University of New South Wales, orthopedic surgeon at Liverpool Hospital, and a VMO at St. George and Sutherland Hospitals. His interests include orthopedic trauma, evidence-based medicine, and clinical research. He also wrote a book a couple years ago in 2016 called Surgery, the Ultimate Placebo, and that is what we're here to talk about today. Questioning and examining the efficacy of certain surgeries. Do they work or not? And if they don't work, should we keep using them? That's what we'll let the evidence decide. So welcome to the show, Dr. Harris.
Thanks for having me.
So I think I want to start out with just like a brief Coles Notes synopsis of what your book is about.
Yeah, the book is, broadly speaking, it comes from my suggestion that the evidence and the effectiveness of medicine is very much overestimated. And I think along with that is that the harms from medicine are also underestimated. And I chose surgery in particular because that's my area of clinical work, and also because people don't often see surgery like that. I think if you said that, this drug was no better than placebo, people would believe that. They understand it. They go, yeah, not all drugs are effective. Some of them are good, some of them aren't. But when you say, well, this surgical procedure actually doesn't work, it's no better than pretending to do it, that's a little bit less obvious to people. It's kind of like, why would people be doing this operation if it didn't work? It doesn't make any sense. And so it was really to open up that conversation. It's like, it's not just drugs or other, physical therapies or other things that are ineffective. It's actual surgical procedures, many of which are ineffective. And so the book covers the history of that, and also talks about why. What are the biases that surgeons have? What are the forces, the enablers that go into this positive attitude that we have towards surgery, and how we can be a little bit more realistic about it and how we can correct it.
Okay, so that's interesting. I think we should I like the idea of just going back in history. How did surgery become such like a dominant mode of treatment in today's medicine?
Yeah, the history is really interesting. The historical example that I use in the book is one of venesection or bloodletting, because this was a very common tool. In fact, it was one of the main tools used by doctors for hundreds of years. In fact, thousands of years. The history of bloodletting goes back. And
bloodletting, is that like draining blood from the body as a way to treat people?
Yeah.
Wow.
Yep. So it's called venesection if you take it out of the veins. Leaching. People used to use leeches to drain blood from the body, and they would drain different amounts of blood on different times of day, depending on the illness. And this whole science was developed around bloodletting and how to do it best and how to treat pneumonia different to something else. And it was basically what doctors did. And it got to the stage where it was really farmed out to those who held the lancet or the knife. And they became the surgeons. And for some time there, the surgeons were combined with the barbers in the Guild of Barbers and Surgeons in England. And they would cut your hair, they would take some blood off you, and extract teeth, all sorts of, I guess the beginnings of surgical procedures. But it wasn't really until anesthesia came about in the 1800s that it became possible to do really quite major operations. And then it was antisepsis that made those operations safe. So the two things that combined, one was able to put the patient to sleep, and the other thing was able to ward off infection, that made surgery really, a possibility. And for some things, it was great. But the early examples tell you about how misguided people were. I mean, taking out lumps and bumps. I mean, we weren't sure what we were doing back in those days. History of mastectomy is interesting. That was really a race to see who could do the most invasive procedure. They had mastectomies, and they had radical mastectomies, and then they had super radical mastectomies where they would take off the breast and the muscles all the way down to the chest wall. I mean, these brutalizing, horrific operations, which added nothing. They added nothing to the patient. It was just an idea that surgeons had that, well, gee, if a radical operation is good, then a really radical operation is probably better. And it's this kind of, it sounds good, therefore it probably is true mentality that drives a lot of surgery. A lot of surgery that's done today, it's kind of like, yeah, this seems like it would work. Let's do it. And instead of getting the scientific evidence to find out if it does work, by testing it, we're just doing it. A lot of the patients seem to get better, so it's probably working. But that's really, I think, in the 21st century, that's really no way to be judging the effectiveness of an operation. It really should be held to the same standard as drugs or as other forms of treatment.
It's funny you mentioned that. I read the book The Cancer Industry by Ralph Moss, and some of the cancer treatments that they've been doing as recently as like I think they stopped around the 70s, but they're like ripping out organs left and right. It's pretty intense. And he talks about how, like, as a surgeon, the more you cut, the more you get paid. So I think just from that alone, like as a patient, I think it's dangerous not to question whether these things are justified or not. So the fact that you're bringing forward all this evidence and it gives people information that can help them decide what they want, I think is amazing.
Yeah, people think that cancer treatment is, it's pretty straightforward. It's well studied. There's lots of evidence there. So, we'll just let the doctors go. But yeah, the evidence is a little skewed, particularly around end-of-life care, terminal cancer and things like that, where, people are throwing third-line, fourth-line drugs at people, subjecting them to, horrific sort of chemotherapy for really no gain at all, just on the sort of the hope that maybe, this is the one. And for the end-of-life care, maybe the patient's better off, being at home with their family and not spending the last 6 months of their life in intensive care. But even another good example I use in the book is for breast cancer treatment. They developed a treatment which was basically severe chemotherapy, and it was so severe it just wiped out your bone marrow. And so they did a bone marrow rescue, basically like a bone marrow transplant. And so this was like the ultimate in radical treatment, where it just wiped out your whole body's immune system, and then it got replaced with a bone marrow transplant. And this became common treatment in the 90s, 80s, I think, 80s. And it got to the stage where insurance companies, because it's very expensive, so some health insurers in the United States were saying, well, gee, we're not paying for this, you're not covered for this, this is really expensive and we don't have good evidence. And insurance companies were being sued for not providing it. And it wasn't until after it had become common practice that they did the trials comparing bone marrow rescue to not doing it, just doing standard therapy, and they found that the bone marrow rescue was no better or worse. So people stopped doing it. But it became this mentality that, well, it's a stronger treatment, therefore it's better. And it just wasn't the case, but we believed that it was.
That's fascinating. I actually wrote a book on cancer, and I'm not a doctor, so I mean, I don't necessarily believe in authority as it is, but as far as deciding what I want to do, I always look at evidence. So this book has like 2,300 scientific studies, and I think the first, like when I reviewed cancer surgery, I found that as early as 1904, there was a study by Mary and Clunet, and they found that incompletely excised tumors from mice caused it to spread. That was like the most common cause of metastasis. If you didn't touch it, it wouldn't spread. So there's some evidence that should at least make people want to question these things, I guess. And I think that's one of the biggest reasons I wanted to have you on the show. And I'm really happy to have you here. I think the next question I want to ask, first of all, I've had a knee injury about 23 days ago, actually. So about 3 weeks here. And I just had my MRI yesterday. So I'm getting to the point where my doctor was going to look at that after the radiologist hands it to her, and she may recommend me surgery. So for myself, and so others can also hear it, this is one of the reasons I wanted to do the show. But before that, do you have like a list of just surgeries you can rhyme off that you think may not be justified and we should never do again, and ones that you think are really good and that we should continue to do?
I don't really have a complete list. I cover a lot of it in the book. The example that you just referred to regarding your knee is widely covered in the book because that's my area of specialty. But yeah, some cancer surgery, cancer screening is another thing in general. So prostate cancer screening, breast cancer screening by mammography, lung cancer screening, other types of thyroid cancer screening. These are programs that are widespread and sucking up, millions of dollars going towards the industry that supports this kind of thing. And the evidence for it actually saving lives is very low or marginal at best. Within my particular field of orthopedic surgery, the two areas that I focus on are knee surgery and spine surgery, because there's a lot of spine fusions being done, the lower back in particular, but also in the neck, for back pain and for other spinal conditions. And the evidence for that is really not very good at all. And you can suspect that there's something wrong when you see a lot of practice variation. So if you look at the rate of spine fusion in the United States, it's completely off the charts. I mean, they're doing, there's hundreds of thousands, I think like 500,000 or something spine fusions a year. I mean, it's like 500,000. That's this crazy stuff. And you look at other countries like the UK where the rate per 100,000 or per million people is much, much lower. And even within Europe, the countries vary hugely. And they haven't done the studies that they need to do. And one of my aims in my research is to do more of this research, comparing surgery to placebo. And this has been done in knee surgery. So for meniscus tears, when arthroscopic surgery or keyhole surgery became possible, it became popular. Because now you had a procedure where we could see inside the knee very clearly. We couldn't see much on an X-ray. We can't see much on an ultrasound. They didn't have MRIs in those days. But we could see with our own eyes the architecture of the inside of the knee. Well, that was a big advance. There's no doubt about it. A big diagnostic advance. The trouble is, everything we saw, we thought was a problem. So in the early days, we used to see these folds in the lining of the knee. We called them plica or plicae, plural. And then so when somebody came with a sore knee, we saw this plica. We said, oh, you've got plica syndrome. And we'd remove the plica. And it turns out the plica, of course, is just normal. It's just something we hadn't seen before because you don't see it on an X-ray. And because we saw it, we thought it must have been the cause of the problem. So we were chopping out plica left, right, and center. We don't do it anymore.
Sorry, was it the MRI that made that possible?
No, it was the arthroscopy that made it possible.
Oh,
We originally arthroscopies were diagnostic. We could put a camera inside the knee, and we could look all around the knee. But what happened was we'd see all these things that we didn't know were there, and we'd say, oh, that must be pathological. And we'd chop it out. And then it was only like 10 years later, we thought, isn't it funny that everybody has this pathology? Maybe it's normal. And same thing with meniscus tears, because as we age in particular, we see dehydration and cracking in the cartilage and fibrillation of the lining of the joint. And we see splits and minor fraying of the meniscus, just like we see all around the body in our tendons, in our wrinkles in our faces and things like that. And so we tended to think that this was the cause of the pain. And we do this all the time as doctors or as human beings. We jump to conclusions. If we see something on a scan or on a camera image and the patient's complaining of pain, we tend to say, well, whatever it is I can see is probably causing your pain. So if you come to me with knee pain and I can see a small crack or a tiny split in the meniscus, I'm going to say that's the cause of your pain, even though studies have shown that patients with those tiny cracks or splits in their menisci more often than not don't complain of pain than do complain of pain. So it's not all that clear, but we just jump to conclusions. And you come to a spine surgeon with back pain and they do an MRI and show that there's dehydration or bulging of one of your discs. They say that's the cause of your pain, even though nearly everybody over the age of 40 out there has got a dehydrated bulging disc, and most of them don't complain of back pain. They don't think about that. It's too easy just to match up what you see to the patient's symptoms.
Yeah, so I guess increase in the ability to see inside the body with new technologies makes you see things that you never saw before. So then sometimes you jump to conclusions and think that that is something that shouldn't be there. It sounds like you're saying.
Yeah.
I want to put on the screen now. These are my ultrasound results, and the radiologist said, based on these, that I had a large knee effusion. Roll through this here. Here's the main one.
Yeah. Now, can you see the structures inside the knee really clearly there?
One sec. No, I don't think so. I can't interpret an ultrasound, but
No. What do you see? You see a whole bunch of lines. Yeah, that's really unhelpful. Ultrasound of the knee is really not recommended. I'm surprised that you had one. An ultrasound of the knee is really no better than clinical examination. I can tell from looking at your knee if you've got an effusion in your knee or not. I don't need an ultrasound
from the outside.
to tell that. Yeah, because it's the swelling. It's fluid in the knee. I can feel by touching your knee and even looking at your knee that you got fluid in your knee or not. I mean, that's a very simple diagnostic test. You don't need an ultrasound to tell that.
Makes sense.
But even if it's small, even if it's of any clinical relevance at all. I mean, I've got a very, very small effusion in my knee, and I use it to show my medical students how to test for a knee effusion. Never had a knee problem in my life, but it's so small, it's only a couple of mil. But an ultrasound and a knee effusion says there's fluid in the knee. It doesn't tell you what's causing the fluid. So an ultrasound that says you've got a knee effusion is a complete waste of time. Nobody here recommends ultrasounds to investigate a knee. If you've got a knee problem, it's a low yield test, and it has low specificity.
What about X-ray for the same, like looking in the knee as well? Would that be useful at all?
Probably the two biggest things we use for looking at knees is an X-ray, because you can tell big things, right? You can tell if you've got a fracture. You can tell if you've got a arthritis in the knee very easily on a plain X-ray. You don't need to do much else if that's what the diagnosis is. But an MRI is a very detailed test with high sensitivity and high specificity that can show you not only the bones, because an X-ray just shows you the bones, but it can show you the menisci, it can show you the lining of the joint, it can show you the ligaments inside the joint. If you've got a torn ligament from a sports injury, it's very easy to see on a MRI. It's impossible to see on an X-ray, and it's almost impossible to see on an ultrasound. So there's two things that, the only two things we do to investigate knees, basically like 99% of the time, is we do an X-ray and we do an MRI.
Okay. Well, I'm really happy to hear that, actually, because I've heard one of the people that I research that I enjoy reading is Dr. Ray Pete, and he's been saying that MRI is one of the safest and most effective ways to go. So,
Well, it is very safe because it doesn't involve any radiation, which is what
yeah.
CT scans, for example, involve. So, but that's why it's become so popular. But there's a downside of MRIs because anyone with a niggling back pain, wants to get an MRI. And I recently had a Twitter feud with a guy. I weighed in on this argument that I saw, and this guy from Germany said it should be the right of every person to go to their doctor and receive a whole body MRI every year, just to check, to pick up things before they become a problem. Now, on the surface, it's hard to argue with, isn't it? Like, if, and somebody argued about the cost, and I said, okay, cost aside, let's just say, for example, we could do MRIs for like 2 cents or something, it just became, the technology suddenly became very cheap. I still wouldn't recommend it. They're going, why wouldn't you recommend something where we could get a whole body MRI? You look at your whole body, your organs, not just your knees, your brain, your spine, everything. You could pick up things that might cause problems and get to them sooner. Well, it just doesn't work like that. For the same reason, cancer screening largely doesn't work. It's what you find is a whole bunch of things. You do an MRI of your whole body, you're going to find all sorts of things. And then what are you going to do? You're going to say, well, gee, now we're going to need a biopsy. Now, I don't know what I found a little lump on the right side of my chest just near the top. Okay, now I'm going to need a biopsy. And you get a complication from the biopsy, or you go through the stress of worrying what you've got. Then it turns out it was just nothing. It was just a smudge on the scan or whatever. But before long, they're really not sure, so they're doing more scans, and that shows something slightly different. Now the doctors are really confused. They're going to have to go in there and take a chunk of your lung out just to make sure. And they've done studies like this. They did a great study in the US where they had primary care physicians, and they said, okay, for every patient that comes in complaining of back pain, we're going to randomize them to either get an x-ray or get an MRI of their back. Because you think the MRI would show more, be better, and you'd be able to, better treat the patient and focus your treatment appropriately. And they found after 12 months, those that were randomized to pay an x-ray were doing no better or no worse than those who were randomized to an MRI. The quality of life, the back pain was no different. The only difference was those who were randomized to get an MRI were more likely to have had surgery in the meantime.
Oh.
Because they just found stuff.
Mm-hmm.
And they find stuff, you refer it to a surgeon. Surgeon goes, well, I don't know, I can operate on it, I guess, we'll see how that goes. And this is what happens. And it's happening today with people's spines.
Yeah, I guess you can't get diagnosed with something if you don't get tested for it. So the fact that, like, for example, cancer treatments are so profitable makes it kind of scary, the idea of getting tested for it, something that people should be, I don't know, weary about, I guess, and just see if they think it's, I guess the more you get tested, the more likely you might get diagnosed with something is what I'm trying to say.
Yeah, but it goes to the philosophy that diagnosis is a good. It's a universal good. There can be no downside from being diagnosed with something, but that's clearly not true. And there's lots of examples to show that.
Okay, so your book, the thing that interests me is the fact that you're talking also not only about unnecessary procedures, but you're also like talking about the virtues of placebo, the placebo effect, which is a fascinating subject too. So what do you suppose the solution is? Should surgeons retire their scalpels and secretly do sham surgeries without telling the patients? Or should we look at the evidence and be honest about what surgeries don't appear to be effective and just never do them again and change the way surgeons do things?
Yeah, I think the latter. I'm not a fan of using the placebo effect for several reasons. And this has been suggested in all the talks I give. It's often a question that comes up, And I had dinner with a friend of mine who's an orthopedic surgeon. And we were talking about this study that had come out comparing knee arthroscopy to placebo surgery, where they pretended to do an arthroscopy, showed no difference. And he said, I think that study's great. I'm doing more arthroscopies than ever. And I said, oh, that doesn't make sense. Like, why, you should not be doing it now. And he said, no, it's great, because if you look at it, most of the patients got better in both groups. And he said, I don't care whether it's placebo or not. If most of my patients are getting better, I'll keep doing it. And of course, what he's missing, and so he's attributing this to the placebo effect, and this is what a lot of people falsely do, is they say, okay, well, the patient got better because of the placebo, so that's fine, or whether you call it a placebo or not, they still got better because of what I did. And that's not true. They're still assuming causation. And this is the fallacy that so many people fall for. They assume that what they do is causing the result. And when you look at the placebo effect, and I think I probably regret calling it placebo effect, because it's really not due to the placebo. A placebo, by definition, has no effect. That's the definition of a placebo. So it is confusing when we talk about a placebo effect. And some of it's got to do with context and maybe expectations, but most of it is due to two other things, and that's natural history and regression to the mean, and it's basically what would happen to the patient anyway. And so when somebody goes to a homeopath with with a cough or something, homeopath will give them some medication. Within a week, the cough's gone, and they'll say, there we go. They got better because of my medication. An opponent might say, no, they got better because of the placebo effect of what you gave them. But I would say, no, they just got better anyway. They would have got better if they had never seen you. And this is why every cure for the common cold works, because the common cold just gets better anyway. Mm-hmm. And in knee pain with arthritis and degenerative conditions, the same thing. I see patients all the time. They come in and they say, yeah, I've had a bad knee for a while, ups and downs. Sometimes it's bad. Sometimes I get by. I'm still working, and it's, it hasn't bothered me too much. But the last couple of weeks, it's been really bad again. Now, in a couple more weeks, they're going to be better again. It's just part of the up and down of having an arthritic knee. But if I operate on them today, and I see them in a couple of weeks, and I say, how are you feeling? They go, yeah, it's a bit better than it was before I saw you. And I'd say, yeah, that's due to the surgery I just gave you. And it's not.
Of course.
And it's not due to the placebo effect of that surgery either. It's due to the natural history of the condition and the fact that I happened to get them at a bad time. So, no, I don't think we should be using the placebo effect because of the reasons I've just explained, also because of the costs involved, because of the deceit involved, and because of the potential harms of conducting surgery on someone for no conceivable benefit. And because the placebo effect, there's an argument that there is no placebo effect, that it's all due to these other things. But if there is one, it's weak and short-lived. And as soon as doctors put themselves up there as being science-based, and doctors are the first ones to call out alternative medicine practitioners and naturopaths and just say, you guys haven't subjected your treatment to placebo, randomized trials, and we're scientific and you're not. As soon as they say, well, we're just going to do it anyway, we're just going to use the placebo effect. As soon as doctors do that, they've just removed the only barrier that exists between mainstream medicine and alternative medicine. That barrier is gone once we start doing that.
Okay, I'm just trying to look at the time here. I know this program has a 40-minute limit, so I think it might just cut out at some point. So that might be soon. So I think we should probably wrap this one up. I guess my last question would be this. Actually, sorry, one short question before that. What do you think the chances are that if the doctor recommends me arthroscopic surgery and I get it, that will benefit my knee?
Depends what's wrong with your knee.
Oh.
So if you had an injury, if you had an injury to your knee and you've got a torn ligament, and your knee is unstable, then the arthroscopic surgery to reconstruct the ligament can be helpful. If you just have a very small meniscus tear and a little bit of fluid in your knee, I'd probably just sit on it and wait and see how it goes. But nobody's going to do that until they do an MRI first and find out what's wrong with it.
Yeah. It's amazing how far I've come in the past week. I went from crutches and pain every single step to now being able to walk without them. I'm hitting the knee with near infrared light therapy every day, so it seems to be working. I don't have a duplicate of myself with the same knee injury and not administer near infrared light to see if it's working or not, but it feels like it's really helpful, you know?
Nearly all knee injuries get better.
Yeah.
Yeah.
All right, so my last question here. If there's just one thing, one concept or idea that you think is the most important from your work that you want everyone in the world to know because it would reduce the suffering and make the world a better place, what would it be?
It would be to say that the effectiveness of medicine is overestimated by those who are making the decisions, and the harms are underestimated. So the doctors themselves are overestimating the benefit and underestimating the harm of medicine. The way to correct that is to make doctors be more scientific about what they do, and also to educate the public to be more scientific about what they will have done to them. Don't be afraid to get a second opinion. Don't be afraid to look up the evidence, and ask your doctor simple questions. You know, I always say the simplest question of all, and it sounds dumb, but so many unnecessary procedures could have been saved by asking this single question: is what evidence do you have that doing this procedure to me is better than not doing it to me? It's a really simple question, and that's what it all boils down to. So if somebody says to you, I think you need a knee arthroscopy, say, what evidence do you have that doing a knee arthroscopy on me tomorrow is better than not doing a knee arthroscopy on me at all? It's such a plain and simple question. Nobody asks it, and not many doctors can answer it. And sometimes you get a surprising answer.
Oh, that's great advice. Well, thanks so much for being on my show here. It was a pleasure interviewing you, and really happy to get your message out there.
Great. Thanks very much, man.
Take care.